Hi, I'm Madeline Sendek. I am the ASA Monitor Multimedia Publication Specialist, and today I'm talking with Dr. Miller about his column, The Curious Economist. Welcome, Dr. Miller.
Welcome. Thank you for having me.
It's great to have you here. So to start off with, let's discuss the healthcare cost elephant, your article that has the most page views among all of your column articles so far. Why do you think this has captured the reader's interest?
Well, I think the word cost is something that is so broad and so misunderstood and probably not well documented or defined. So probably we had all sorts of people looking into what we meant by cost. Was it supplies, drugs, equipment, a procedure a physician was doing, cost to the hospital, cost to society, cost to the payer, the taxpayer? You know, what did we mean by cost? Cost is way too generic a word. Was it incremental cost, full cost, getting into some accounting terms? So I think probably because of one, everyone gets confused about it, even I do, because of the way some things are written. So it's a confusing topic. It's not well standardized in terms of what we mean by cost, and it means different things to different people. So I think it drew a lot of attention. And the cost element is sort of can be looked at from two perspectives. The perspective in the article is that it's all different to different people, sort of the story of the blind man and the elephant, or the other side of it is that the elephant in the room, that no one likes to talk about cost. So I just think it was a good one to start off in early on in the column, because I think it's just of great interest, and it may be revisited because it does mean so much and so many different things to many people.
Great. And what topics do you anticipate covering in 2022?
So if I had my crystal ball, I think we're going to get more into the workforce again, longitudinal sort of look at where people go right out of school. Where do they end up? How do they transition over their career? These data are not easy to find, but we do have some good data sources that we're building upon that to kind of take a look at. The whole concept of compensation for physicians and anesthesia professionals versus the payment for those services, that gap I think is getting bigger and making life a little bit more difficult for everyone. We know about Medicare not paying its fair share, if you will, and so someone has to make that up. And so there are some economic concepts. I think that the continuing with the industry structure and getting a better sense of the large groups of the hospitals, the health systems, some of the consolidation and things like that, and how that affects the workforce specifically. But those are my initial thoughts. Competition is always a big deal. The labor substitution between nurses and physicians, and that's always a big deal. So anything we can get our hands on, and then of course when something pops up like COVID, we hopefully not again, but we can have an opportunity to look at some of the implications of that. So yeah, I think there's a lot still out there. The data we have, I think, are getting better and better and better. And there are a lot of other researchers out there doing some really good work that hopefully we can summarize some of their work and kind of bring it down to terms that everyone understands.
Okay, and your most recent article in the January ASA Monitor is how much does that non-physician anaesthetist cost? Can you explain what you found while examining the non-physician anaesthetist cost data reported by rural pass-through hospitals?
Yeah, so that was a very specific look at those rural pass-through hospitals out there that are able to get paid based on a reimbursement of costs associated with nurse anesthetists. And you do that by looking at the hospital cost reports, which are very long and tedious to look at and very difficult to fill out, large documents. But it is through that process where CMS starts to pay for nurse anesthetists in these rural pass-through hospitals. And those rural pass-through hospitals are the ones that are just have a single, no more than one FTE CRNA. They have to be rural. Most of them, but not all of them, are critical access hospitals. They can't do more than a certain volume of surgeries. And so it's a way for Medicare to help support some of those hospitals My interest, of course, since I do have some experience on the cost report side, is to kind of look at outliers and variability. And so this is one area where there was a tremendous amount of variability and outliers. And so in general, everything looks reasonable. You get very detailed. I specified in the article which line items from the cost report we looked at, just for anyone that wants to follow it, to get very specific. But you know, notice some odd things. Obviously, many of these smaller hospitals, they don't need a full-time equivalent CRNA, so they have contracts with part-time folks or contracts with other services, or they have someone that is in fact part-time. But everything seems reasonable. But then you have these outliers where if you look at the expenses associated with the non-physician anesthetist, which is what it's called in the cost report, you have a few places where the quote expenses for the year were over $1 million or $800,000. Just things that hard to make sense of what really that means. The cost report data is so difficult. You know, we have over 600 and so rural pass-through hospitals, but not everyone who identify themselves as a rural pass-through hospital complete the full document to get reimbursed its fair share from Medicare. So there's some incomplete data in there that's always interesting to look at. But the big thing we found was tremendous variability and a few of these outliers that, you know, we just can't really explain. And the cost report data is somewhat limited. We don't know what actually Medicare handed over in terms of a check for some of these things. We only can kind of interpret what the regulations say. But there's certainly some things in there that are kind of interesting or different. Now, on the other hand, Medicare will pay for a reasonable cost for a full-time nurse anesthetist, no matter what type of services they provide to the facility. So there's a lot of things to look further at, but I think it does raise some flags, and it does say that Medicare does recognize the value of anesthesia services, and so it's sort of a first step that we're going to take to another step probably this year, where we look at the amount of specific services provided in those facilities and come up with what we call an equivalent payment per service based on the sort of payment that Medicare does. Doesn't reimburse places anywhere else other than rural pass-through hospitals on this basis of cost. So something that people are interested in. I think ASA did a study 10, 11 years ago, and this is just sort of an update to take a look at it. Variability and these wild expenses are the biggest interesting findings from my perspective.
Why do you think economics are at the heart of medicine in this issue and many of the others that you've covered so far this year?
Yeah, I would almost change that to, I think understanding the economics is at the heart of sustaining a good healthcare system. And when you have national health expenditures that are getting close to 20% of the gross domestic product of the US, $4.1 trillion, which $1 trillion, it's really hard to get your hands on how big that number is. So number one reason, it's a gigantic part of our nation's economy. It's, you know, almost 1 out of every $5 is spent in healthcare. So it's a huge part of it. The other thing is it's a very confusing part. It has elements of economics, elements of social service, elements of technology, religion, business. It's just very complicated. We have the complications of who's actually paying for it. Taxpayers, businesses, employers, insurers, individual patients, then their families. So, you know, last few years, a couple of the big issues had to do with out-of-pocket expenses and surprise billing. And so there are a lot of components to it. So I think it's at the heart because we need something that big. We really do need to understand the economics and what it implies. And I think that's so that we can make perhaps better decisions in the future and understand the implications, because it does have huge economic issues, but there obviously are also social and political issues that are very important. But I think it's at the heart only because of the sheer numbers. 20% of the gross domestic product is somewhat mind-boggling.
And do you think the average anesthesiologist receives enough training in economic issues by the time they start practicing?
I don't think the average person receives enough training in economics, or especially I think in colleges we could I mean, we definitely don't have enough economic training in our colleges. Having said that, you know, it's a trade-off. It's opportunity cost. Yes, it'd be great if they could have more training, but if that means that they, you know, we only have a so amount of time for training and education, and if that means that they lose some time for medical education or something that's more specific to the specialty, I'd hate to see that trade-off. I'd rather them be clinical experts and geniuses as they are, as opposed to knowing a little bit about economics. We all have opportunities to learn more about economics once they start their practice and do some of the leadership stuff. So I think that's good. To the extent that it doesn't take away from their clinical and medical expertise and training, I'm all for it. But you know, we can't specialize in everything. I would love to know more about quantum mechanics and physics, but I don't have time. So I think in general, those physicians, and there are many, many, many of them that have really good understanding and expertise in economics, I think they benefit their specialty, they benefit their practice. And so that's a great thing. So that would say, yeah, it'd be nice if more people had it. But I think we have to mind our trade-offs that we're talking about here. And if there's some new clinical advances, new diseases or techniques or whatever that needs to be studied and taught in class and sort of teamwork or things like that that need to be taught in medical schools, I'd give way to that. Plenty of economists out there.
And is there anything else that you would like to share with our readers, or a specific article that you would like to draw them towards?
Not really. I think the demand and supply one, talking about Goldilocks and the devil and physician supply and demand, is a good one. Some of the earlier articles, we started out with some basic economic theory, and I think that's always a nice refresher. I just say stay tuned, and at the end of each of my columns, I invite people to send me suggestions, something that's on the top of their mind. I'm very fortunate working at the ASA, being involved in the committees and talking to the leadership. I think I have a pretty good sense on what's on people's mind, but it's always good to hear from folks to say that, hey, what about this and what about that? So, you know, there haven't been that many of them. What is it, every other month or so? So, and they're pretty short, and hopefully they're not boring enough where people can take a look at all of them and just decide, even by the title, which ones are of more interest. But I like the healthcare cost elephant one. You know, you could spend books on that and just volumes and hours talking about it. So there's probably more to come on that.
Thank you so much for sharing your insights and expertise with us today.
Thank you very much.